pages and nearly 50,000 words. To give you an idea of really how long that is, a novel is defined as having 50,000 words. So this is what the government sends you for you to make a decision for the rest of your life when it comes to healthcare is a nearly novel length guide. So we know that Medicare can be a very, very confusing and complex topic. I won't be able to tell you exactly the right course of action for you individually today. That's ultimately going to be a conversation for you to have with your family, with your financial advisor, as well as finding a trusted resource, possibly local, but even just someone that's licensed in your state to make sure that you're able to see all the additional plans available to you. What we do, or what we can do at the time we have this afternoon, is to go over everything you need to know in order to make that informed decision. We'll talk about what original Medicare really is, that's parts A and B, what it covers, and what it costs. Then we'll talk about the additional plans you'll likely be considering in order to have comprehensive health care in retirement. And we'll wrap up with talking about when exactly it is you need to apply to make sure there's no gaps in coverage and no costly penalties coming your way. But up first with original Medicare, how to qualify for it is pretty easy. It looks and feels a lot like Social Security. You need to pay into Medicare for 40 quarters, pay those taxes for 40 quarters. If you yourself have not, but your spouse has, that will also qualify you for Medicare. Generally, you need to be age 65 or older. However, if you're on disability, SSDI, for 24 consecutive months, you can qualify in the 25th month. Or if you have end stage renal disease, which is kidney failure, or ALS, more commonly called Lou Gehrig's disease, you can qualify for Medicare as soon as you qualify for Social Security disability as well. And Medicare has a very large network. Most of the doctors that you'll see are probably participating in Medicare. 90% of non specialist doctors in America are a part of the Medicare program. The first part of original Medicare is Part A, which is oftentimes called hospital insurance, but it's a much bigger program than just going to the hospital. It can cover up to 100 days in a skilled nursing care facility after you're discharged from the hospital, inpatient nursing care, as well as home health care and hospice. Now, specifically see in the parentheses, though, it says not long term care or custodial care. If there's the chance or the plan of you going into a care facility, or if there's maybe a family history of Alzheimer's or dementia that could pop up as well, Medicare will pay very little of the care and probably none of the room and board for those facilities. So that's something that is in consideration. You'll either need to budget appropriately or make sure that you have alternate insurance that can help you offset the cost of those facilities. Medicare Part A is going to be premium free for 99% of the population that's out there. However, there are still costs for the care that you get. Just to give you a sense of what it could look like, say you need to go to the hospital. The first thing to know is that you need to be admitted as an inpatient for Part A, not just in the emergency room, not just there overnight for observation. You need to be admitted as an inpatient. Once you are, that sets off what's called a benefit period. Benefit periods last 60 days. So if I were to go to the hospital on January 1st, discharge the next day, go again on July 1st, that is two separate benefit periods. But once I'm admitted, then I'll have to pay a $1,632 deductible. And then for the first 60 days, Medicare picks up the cost of my stay in the hospital. If I'm there days 61 through 90, it's a $408 copayment. If I'm there day 91 moving forward, I'll start using up what's called my lifetime reserve days. While I'm using those up, and we all just have a bank of 60 of these and they don't get replenished, I'll pay an $816 copayment. If I'm in the hospital for 150 days, or a second very long stint in the hospital where I've used up my lifetime reserve days, then I'll pay all the costs associated with my hospitalization. Now, I really hope none of us have to be in the hospital for 60, 90, let alone 150 days. But there are some horror stories about folks with rare illnesses or hard to treat diseases that have been in the hospital for extended periods of time, and then they and their families get high six and even seven-figure hospital bills. The second part of original Medicare is Part B, which is usually called medical or doctor's insurance. Part B is another really big program. Covers things like preventative services, CAT scans, mammograms, things of that nature. Part B does cover emergency room visits as well as urgent care. The third bullet point you see here, durable medical equipment, is a major component of Part B. That's canes, walkers, wheelchairs, hospital beds, but it can get much more esoteric than that. It can be things like blood test meters or blood test strips. And then in very limited ways, Part B can cover prescription drugs, clinical research, and mental health care. Unlike with Part A, there is going to be a cost month over month for Part B. Most people in the United States will pay the first number you see in that blue column, $174.70. You'll see that this can climb though, gets up to $594. That's called an income related monthly adjustment amount, or an IRMA. And although it sounds like your friendly Aunt Irma, it can be really, really costly and sometimes takes people by surprise. The reason for this is that Medicare is basing these premiums off of tax returns and filing status from 2 years earlier. So if you're turning 65, you're planning on retiring, going on Medicare, they're still basing your premiums off of 2 years prior when you were working to determine the month over month cost. And a lot of folks have thought, I got to eat that. It's the cost of doing business with the US government. You don't, though. There's a form from the Social Security Administration, which is called SSA 44. This is a life changing event form. If you've had a major life event that drastically alters your income moving forward, things like retirement count, the death of a spouse, if you get divorced, that can also count. You can petition Medicare to lower these premiums to the more appropriate level, saving you at least $70, but maybe hundreds of dollars over the course of the first 2 years that you're on Medicare. Over the last 10 years, I've had conversations with a lot of folks about I've been on Social Security and Medicare for quite a while. This year, my Social Security check went down even though there was a COLA. Why did that happen? And it's not that their Social Security benefit went down, but it's that their Part B premium spiked for 1 year. And we'll ask a couple questions and find out 2 years before they sold off land, part of a family farm, a vacation home, maybe even just downsized. And then 2 years later, that amount caught up with them and spiked their premium. Unfortunately, for those one time major windfall type events, that form that I just mentioned does not apply. Aside from the Part B premiums, there's also going to be cost for the care you get. There's a low deductible for Part B of $240 a year. Then Medicare will pay 80% of the approved cost of treatment, and we'll have to pay the remaining 20%. Approved cost is a bit of a tricky phrase, though. Many doctors accept what's called assignment. Assignment means whatever the Medicare approved cost is, that's the billable cost. If I see a doctor that accepts assignment and the approved cost is $100, after the deductible, I'll pay 80 and or Medicare will pay 80 and then I'll pay the remaining $20. Some doctors do not accept assignment, however. They can charge more. They can charge up to 15% more. So that means Medicare would still only pay 80%, the original $80, but now I'd be on the hook for $35. So when you're going on Medicare, if there's a doctor you like to see, it literally can pay to ask them whether they accept assignment or not. So that way there's no surprise costs for the treatment you want to get from the doctors that you want to see. And while Medicare A and B is a really big program, there's a lot of things that it doesn't cover that we've gotten accustomed to. Things like dental care, eye exams, denture fittings, things like that. Routine physical exams are not included in that Part B component when they say preventative services. I tend to think of Part A and B a bit like a new car if you're going shopping. They're the base model. They're going to get you rolling down the road, but probably don't have all the features you want for the healthcare in your retirement. That's where you'll need to consider other forms of insurance to make sure you have the more comprehensive coverage. The first plan we'll talk about is Part D, which is for prescription medications. Even though it has that letter D, it is not offered through the government, it's offered through independent insurers. The first thing you'd want to do is write down a list of any medications you're on because we need to check those medications against what's called a plan's formulary. Formulary is just a really fancy word for the list of medications that the plan will help pay for. To make things more convoluted, they usually will assign medications into one of 5 tiers. Lower tier drugs are going to be less expensive, generic versions of medications. They're going to have lower copays. The higher tiers are more expensive, specialty, name brand medications. They'll have higher copays along with them. The premiums for these plans will vary year over year, and they usually or vary plan by plan, and they usually fall into one of two categories, either what's called a basic plan or an enhanced plan. Usually the cost between the two plans isn't unnecessarily large. The IRMAs we talked about, They also apply to Part D plans, and a best practice is to make sure you review these plans annually. The reason for that is that pharmacies could move from in network to out of network. We don't want you paying more for medications just because a pharmacy nearby has moved out of network. Or what happens more commonly is that someone may get assigned a new medication in the middle of the year. We want to make sure that it's part of that plan's formulary so you're not paying an unnecessary amount out of pocket. So that way we can find you a new plan that does cover it. One of the big areas of confusion has been around the phases of these Part D plans, particularly phase three, which is officially called the coverage gap, but is more commonly called the donut hole. But phase one's the yearly deductible phase. You'll have to pay a certain amount before the plan kicks in. Some plans have very low or even no deductibles. Then you enter the copayment or the coinsurance phase. There's going to be a regular retail cost for medication. Let's just say it's $500 a month. The copayment could be $50. The coinsurance could be 10%, also $50. If you pay your way into the coverage gap, this means that you plus the plan have spent $5,030 in out of pocket costs. And at that point, you can pay up to 25% of the retail cost of medications. So if it was only $50 during the copayment phase, this could move to $125 during the coverage gap. When this was in the true donut hole era, which ended about 4 years ago, that wasn't capped at 25%. The plans set this limit. So it could have been 50, 75, 100% of the retail cost of medications. But 4 years ago, the government stepped in and mandated the most it could be is 25%. And as the law stands today, the coverage gap goes away completely in 2025. So you'll only need to know about phase one and phase two. But even for this year, if you pay your way through the coverage gap with $8,000 in out of pocket expenses, you enter the very dramatically named catastrophic coverage. And at that point, you wouldn't have to pay any additional amounts for your covered medications, the medications that are a part of a plan's formulary. The other types of insurance that you'll need to consider is either what's called a Medicare Advantage plan or a Medicare Supplement, also called a Medigap plan. I'll start on the left hand side here where it says Medicare Advantage or Part C plans. If you're watching reruns of Frasier at night like I do, this is what a washed up celebrity is trying to pitch you. They basically privatize and replace Medicare. You still need to enroll in Medicare at the proper time, but then you can choose a Medicare Advantage plan which privatizes and replaces Medicare. They look and feel a lot like group health plans we have while we're working. They're going to have a hospital component. They're going to have a doctor's component. Many of them have Part D, the prescription drug components, rolled into them, and they could have some other features, think things like dental and vision as well. They usually fall into one of two categories, either an HMO, a health maintenance organization, which has a defined and local network, or a PPO, a paid provider organization, which has both in and out of network doctors. To see specialists, you usually need to get referrals in order to do so, and they may also get a little bit of confusion because they're oftentimes pitched to you as no cost or premium free plans, which I think is very misleading because the Part B premium you're paying, you still have to pay that. Except rather than it going to the government, it basically gets forwarded over to the Advantage plan that or the company that offers the Advantage plan. Some of these may also have additional premiums on top of the Part B premium. If a Medicare Advantage or Part C plan replaces and privatizes Medicare, on the right hand side where it says supplement or gap, that's a complement to Medicare. You'll need to enroll in Part A and Part B at the right time, and then these plans can help complement Original Medicare. Original Medicare becomes your primary form of insurance. You'll need to get a Part D plan for any medications, and you can also get your own dental and vision insurance if you'd like, or talk to your eye doctor or dentist to see if there's kind of a club that you can join to offset those costs. Then a gap plan can pick up other areas that Medicare does not cover or pay the things that would normally be on you with Medicare. There are currently 10 standardized gap plans out there, and this is really the alphabet soup. Plan G, Plan N, Plan O, they all cover slightly different things. But depending on the plan, it can cover the hospital deductible. It can cover the 20% copayment with Part B. If you see a doctor that it charges more, some of these plans can also pay that overage. The trade off is that you are paying an additional monthly premium month over month, year over year, in order to have these gap plans. The network is Medicare, So any doctor that accepts Medicare also accepts these gap plans. You can meet with specialists without a referral. To get a sense of what cost could really look like, say you were to slip and fall and need to have knee surgery. Let's say the knee surgery cost $50,000. With traditional Medicare, you can go see any doctor that participates, and you'll have to pay the Part A deductible and the Part B copayment, so around $12,000 all in. With an Advantage plan, you have to go see a doctor that participates, and then there's going to be a deductible and a cost for the plan for the surgery itself. So that could be $3,700 or $5,000. Usually, Advantage plans have what's called a maximum out of pocket, an MOOP. So if you needed to have two knee surgeries in a year, there'd be an absolute top line amount you could expect to spend out of pocket. And then with a supplement or a gap plan, you can go see any doctor that accepts Medicare, and there could be very little to no additional cost for that surgery out of pocket because you're paying more for that gap plan month over month. One of the catches with gap plans is that in many states, you need to choose one within 6 months of enrolling in Medicare Part B in order to have what's called a guaranteed rate of issuance. If you wait beyond that, you could have to go through medical underwriting, which means they can deny you coverage or the premiums could get very, very expensive. So this leads to the last question here. When should you apply? There are 5 different enrollment periods that correspond with Medicare. The two that are most important when you're first getting started is either the initial enrollment period or the special enrollment period. So for the sake of time and sanity, that's what we're going to focus on here today. The initial enrollment period, also called the IEP. This is for when you're turning 65. Are you planning to continue working and have a group health plan? Or is your spouse working and you'll be on their group health plan? If the answer is no, then you'll use the initial enrollment period. This is a 7 month window. It starts 3 months before your 65th birth month, includes that month, and then goes 3 months afterwards. If you enroll the 3 months before, it officially starts the first day of your 65th birth month. Even if you were born on the 15th, it'll start on the 1st. And if you do that month or the 3 months after, it starts the first day of the following month. Everything with Medicare always starts on the first day of the month. There's a couple of catches with this though. If you're working or your spouse or you're going to be on your working spouse's plan, but it's a smaller company, find out how many employees it has. It needs to have more than 20 employees. If it has less, 19 or fewer employees, it is not considered creditable insurance. That plan pays second to Medicare. Medicare becomes your primary insurer. You would need to enroll during your IEP. Or if you're on COBRA benefits or offered retiree benefits after you retire, you can stay on your group health plan. Those also don't qualify. You need to enroll in Medicare during your IEP, and then those plans pay second. The other catch is if you have an HSA, because there's kind of a general rule out there that says, hey, you're turning 65, you should just enroll in Part A. It's not bad advice, but it's not always great advice depending on your situation. If you're still contributing to an HSA, once you sign up for Part A, you lose the tax advantage nature of that, and there can be additional tax penalties later when you take money out of the HSA for those additional contributions after you enrolled in Part A. If you waited beyond 65, but now your work is ending, or you're getting off your spouse's plan because their work is ending, then you're going to enter a special enrollment period. You can do this while you still have group health insurance, usually 2 or 3 months beforehand. Once there's a loss of that coverage, or you retire, whichever comes first, or up to 8 months afterwards. So it's a fairly long runway. There's two catches with this as well. The first still involves that HSA. Because specifically, if you wait till your special enrollment period to enroll in Part A, Medicare is backdating that 6 months from the day of application. So, not 6 months from the day that it takes effect, but 6 months from the day of application. So, if I were to sign up for Part A or apply for Part A 3 months before I lose my coverage because I want to make sure there's no gaps, they're backdating that an additional 6 months, a grand total of 9 months before I would have to stop paying into my HSA. Otherwise, there could be tax penalties. And the other involves if you should have been on Part B. So you thought your company had 21 people, turns out there was only 18, or you thought that COBRA benefits counted, you should have been on Part B. They can attach a 10% surcharge for each 12-month period you should have been enrolled in Part B. If you wait 2 years, That's an additional 20% they tack onto your Part B premium each month for the rest of your life, and there's no way to appeal this. I'm going to pause here in about 45 seconds and hand this back on over to Rich and Mike. But my ask of you is to start this conversation early. Make sure you're having a conversation with your family, work with your financial advisor. I probably said the word cost 30 times during the course of this presentation. I want to make sure that you're budgeting appropriately. The cost of healthcare only gets more expensive the older that we get. And lastly, please find someone you can trust, either someone that is local to you or at the very least licensed in your state that can compare and contrast all the options available. So again, thank you so much. Thank you, Rich. Thank you, Mike. I am more than happy to stick around.
Thank you, Graham. I appreciate it.
Thank you, Graham.
I guess at this point, we'll ask anybody with questions to post them in the chat area. And while we have Graham available, he can answer those. And Graham, another wonderful job if I
Oh,
do.
thank you so much. I appreciate it. I don't do it for the applause, but I'll take it.
You deserve the applause, Graham.
Thank you. Thank you.
I am clapping over here.
Thank you.
Just give it a couple more minutes here. The attendees that are here, thank you for coming. If you have any questions, please post them in the chat area at the bottom. If not, I know who you are. I can see your name. So you can contact me or Rich or anybody directly. Actually, we have access to Graham if we need him and the other people here as well. But on that, since there's nothing coming in, I won't prolong it. There is a replay available. Rich and I will have a replay link to send out to everybody to listen through it, because as usual in our industry, all the information here is really good, but it's like getting sprayed in the mouth with a fire hose of information. So there's a lot to keep track of and a lot to stay on top of. So we'll send the replay out. And just so everybody here knows, we do have people, we don't do the health benefits directly, but we do have people that do them. So if you need a resource in our area, I have people that I can guide you to that could probably answer a lot of the questions you have in your heads now.
Oh, excellent.
But by all means, just give us a shout if you need anything. Thank you, Graham. Thank you, Charlotte. Rich, as always, thank you. I appreciate everyone's attendance today. Have a wonderful rest of your week. And if there's any way we can be a resource, just let us know.
Thanks so much. Have a great day.
Thank you.
Thanks, everybody.